So this is one of the topics that tends to confuse so many people, and there's a lot of confusion. Some patients are often mismanaged because people don't have functional knowledge on how to escalate dosages of antiepileptic drugs, how to decrease them, which drugs you can combine with which other drugs, and the different drug-to-drug interactions. So let's talk about antiepileptic drugs. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at antiepileptic drugs. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. So, before we actually jump into the video, the big disclaimer that I have to put on. Remember that all the information that I'm going to give you here is not exhaustible. You can actually obtain more information from online journals, from pharmacology textbooks. You can also get it from other credible sources about the different drugs that I'm going to present to you in this lecture. This is only meant to be a foundational stepping stone so that you can understand or have an insight as the basics into antiepileptic drugs. So remember, antiepileptic drugs are also referred to as anticonvulsant drugs, or AEDs. And the whole goal or the aim is to treat epilepsy such that an individual is seizure-free without any significantly clinical adverse effects. And this is actually possible in about 2/3 of the patients that actually present with epileptic seizures. And remember, for the treatment to actually be effective, it is therefore important to have a correct seizure and orphan syndrome diagnosis, and this is actually a precondition for you to give them the right drug, because certain epileptic seizures and certain syndromes are going to respond extremely well to certain drugs. But at the same time, if you get a wrong diagnosis, it means that you may actually give the patient a wrong drug and may worsen things. And remember that even these patients that initially responded well to a certain drug, over time they may actually worsen and get into this vicious cycle, especially if badly chosen drugs are prescribed. And remember that the decision to treat epilepsy is actually based on thorough clinical evaluation between a balance between the likelihood of any further seizures and the risk of the adverse effects. Remember that your whole goal of treatment is to abolish the seizures and to keep this person seizure free with minimal side effects, with minimal drug-to-drug interactions. And about 50 to 70% of the patients, they actually become seizure-free just by using one drug. And remember that this seizure-free rate actually varies with the different types of seizures, and it varies with the different types of epileptic syndromes. Polytherapy is actually avoided, and you must avoid it at all costs, but in some cases you may not be able to avoid it. We define it as patients that are often requiring 2 or more antiepileptic drugs, and often these are patients that will fail to respond to a single agent and are going to be accounting for about 30 to 50%. Remember that if the seizure is actually intractable, such that this person still has these breakthrough seizures and these recurrent seizures after a trial of 2 or more drugs, then this patient should actually be referred to an epilepsy center where they're going to be candidates for other modalities such as surgery, other measures such as stimulation techniques such as vagus nerve stimulation, or even sometimes a ketogenic diet. Now remember that for most patients with a few minor or even just sometimes harmless types of seizures, for example, the mild myoclonic jerks, the simple focal seizures, or absent seizures, we may actually allow them to occur instead of us actually just generalizing or generally increasing the dose of the antiepileptic drug or increasing the number of antiepileptic drugs, because once we do this, we run the risk of actually jeopardizing someone who is otherwise socially and mentally well, and also putting them at risk of developing certain side effects. So it is therefore important that all patients that are epileptic patients and all people, that clinicians that are dealing with patients that are epileptic should have some thorough knowledge on these anti-epileptic drugs regarding to the mechanism, the pharmacokinetics, the dosages, the indications, the drug interactions, the acute and the chronic side effects. I will not actually go into a lot of details concerning these things because that will be a pharmacology class. I will do those lectures later on the channel as we introduce more and more series to the channel to make it a wholesome thing. So remember that it is also fundamental that there are special types of groups of patients that have epileptic disorders where you actually need to pay particular attention and extra management for these patients. We call these at high-risk patients. So these are going to be including people like children, elderly, women, especially in their reproductive age, because with anti-epileptic drugs, there's a big risk of teratogenicity. There's a big risk of children being born with neurotube defects. So usually a woman that's taking these anti-epileptic drugs, we often do counsel them of the different risks and that are going to be carried, and they should have some preconception counseling. Of course, I did dedicate a slide in the same lecture to talk about anti-epileptic drugs in pregnancy. And remember, these high-risk groups include also people that have mental and physical disabilities, as these are vulnerable and their treatment is actually much more demanding. Now, remember that some of the drugs, such as PHENYTOIN and VALPROIC, actually, whether they're given orally or they're given intravenously, are going to be reaching their target therapeutic range very rapidly, while other drugs, such as LAMOTRIGINE and TOPIRAMATE, are going to be relatively started at low doses, and then they're going to be gradually increased over several weeks to the standard therapeutic dose based on the patient's lean body mass. Remember that the dose should actually be tailored to the patient's tolerance of the drugs. If they have side effects that are quite significant, then the dose must be reduced. And some patients do have certain drug toxicities even when the blood drug levels are quite low, and others even can tolerate higher levels of drugs without even actually having symptoms. So there's nothing that's like set in stone, and care should be individualized to each and every single patient, and there's no key that can fit every single patient. And if the seizures actually do continue, then we do increase the dose in small increments until we reach the maximum dose. And then if this drug isn't working and it's the first drug that you've tried, you can introduce a second drug, then gradually reduce that first drug and see if this person responds to the second drug. If they don't respond to the second drug and you have reached your maximum ceiling dose, then you can introduce another drug. So the appropriate dose of any drug is actually at the lowest dose possible, such that this patient doesn't have any seizures and they have the fewest amount of adverse effects, regardless of the levels of the drug in the blood. So actually, the blood drug levels must actually be used only as a guideline. And once the drug response is actually known, we should follow the clinical course more, and we find this more useful than actually following the blood levels of the drugs. But of course, if the toxicity actually develops before the seizure control is attained, then the dose is actually reduced to a dose that they had before they had these adverse effects. And then another drug can be added. Then we gradually reduce the first drug that we were putting this patient on, and then we closely monitor them, because if you are dealing with anti-epileptic drugs and you're combining them, they often do tend to have drug-to-drug interactions, which I do mention for some of the common drugs that we use in our setting. Then the initial drug is then going to be slowly tapered off and eventually withdrawn completely. Remember, you should never abruptly stop anti-epileptic drugs. They are all supposed to be tapered off rather slowly. Then use of multiple anti-epileptic drugs generally is avoided because of, number one, there is an increased risk of adverse effects. Number two, is poor adherence. Number three, there is drug-to-drug interactions that are significantly increased. So adding a second drug helps about 10% of the patients, which is very minimal, but this actually doubles the incidence of adverse effects. And remember that the blood levels of anti-seizure drugs can be altered by many other drugs, not just the anti-epileptic drugs, but many other drugs on the market. So please make sure that you check through your drug-to-drug interactions online or through your BNF or your ZNF, depending on whatever you're using. And remember that the physician must be aware of all the potential drug-to-drug interactions. Please check this out before you introduce a new drug, or if a patient is taking multiple drugs at one time. And once this person is actually, the seizures are controlled, the drug should then be continued without interruption until the patient actually becomes seizure-free for at least 2 years. And then at that time, we may consider stopping the drug, and most of the drugs can actually be tapered down every 2 weeks by about 10% until we actually stop the drugs. Now, when we start these anti-epileptic drugs, remember that you mustn't have this knee-jerk response, such that if someone just comes in and they're having a seizure, then you contemplate about starting anti-epileptic drugs. That's not how it works. I had a professor that used to say everyone is guaranteed at least one seizure in a lifetime. And unless if this person is coming in with a status epilepticus, which is a bit different, where we would generally want to start them on anti-epileptic drugs, but a quarter of the patients that are actually already on the anti-epileptic drugs actually do not even suffer from epilepsy. So starting the anti-epileptic drugs often is going to be implying that this person is going to have this continuous daily medication that they're going to take for many years and sometimes even lifelong. So it's very important that you must strictly initiate it for those patients that really need the drug. Those that have unacceptably high rates of seizure recurrency, those that have high risk of seizure injury, and for some patients that do not need prophylactic treatment, just as in febrile and benign childhood focal seizures, then they do not need to be put on any anti-epileptic drugs. Whilst in others, if they just avoid the trigger or the precipitating factor, then they may actually this may be sufficient enough by not giving the prophylactic drug. But others may actually need this prophylactic drugs, for example, those that have a low seizure threshold. Then for those that are in need of this prophylactic treatment, first we must choose the right anti-epileptic drug depending on the type of seizure that this person has. Because remember I said some anti-epileptic drugs can help certain types of seizures, whilst they can worsen other types of seizures. For example, if someone is given the following drugs, tiagabine, carbamazepine, gabapentin, and so on, this may actually aggravate or sometimes may even be ineffective towards the myoclonic jerks, but they do have effect on generalized tonic-clonic seizures. So it means that anti-epileptic drugs that may be beneficial for focal epilepsy may actually worsen and potentially be detrimental for patients that have generalized idiopathic epilepsy. So what are some of the indications, and when do we actually start anti-epileptic drugs? So one, if someone has recurrent seizures of an unknown cause, we want to start them on anti-epileptic drugs. Two, if they have a single seizure with any of the following things. Number one, if there's an identifiable CNS lesion, for example, a tumor, infection, or trauma. If there's an abnormal neurological examination. If they're presenting as status epilepticus. If they present with post-ictal thoughts paralysis, which is this paralysis that is often coming after the person has a seizure, it can mimic like a stroke. Then if this person has a strong family history of a seizure disorder, or if they have an abnormal electroencephalography, usually in the past 1 year. So the anticonvulsive therapy is actually not often initiated in patients that have a single seizure. It's not initiated in those that have unprovoked convulsions and in those that have a normal neurologic examination with normal neuroimaging and those that have an EEG that is normal, unless if they actually experience a second seizure or they have these recurrent seizures. That's when we may contemplate on starting anti-epileptic drugs. Then when we do stop these anti-epileptic drugs, relapse can sometimes happen. Remember, if someone has been seizure-free for the past 2 years, you can actually decide to stop these anti-epileptic drugs. But the relapse is actually much more likely to occur in patients that have a seizure disorder that was stemming back from childhood, if they have been on more than one drug to be seizure-free, if they have had previous seizures while taking anti-seizure medication, if they have focal onset or myoclonic seizures, sometimes if they have an underlying static, which is a non-progressive encephalopathy, or an abnormal EEG in the last year, or any structural lesions that are seen on imaging studies. So for those patients that relapse, about 60% of them are going to relapse within the first year, and about 80% of them will relapse in the second year. So usually these patients that relapse, you want to reinitiate the anti-seizure medication, and most likely if they relapse, they're going to be taking the anti-seizure medication for the rest of their life. Then remember that we want to aim mostly to get monotherapy. So we want to give them a single drug because it has advantages. One advantage is that there is minimal side effects. The second advantage is that there is less drug-to-drug interactions that you have to worry about. and of course the compliance is better as opposed to actually giving this patient polytherapy. So patients should be aimed to actually start a single anti-epileptic drug as wherever is possible, and if the initial treatment is actually unsuccessful, then the monotherapy can actually be tried with another drug. Then if this is not successful, then we can add another drug. So remember, there is some caution that is needed during this changing over period, and switching between different classes or different anti-epileptic drugs must actually be carried out with caution, and you slowly withdraw one drug as you introduce the other one, and you only remove that first drug when you reach the adequate therapeutic doses of the second drug that you're about to introduce. And then if it's polytherapy, which could either be a combination of certain drugs, or it could be adjunct, or it could be adding on to the therapy, this should only be considered after you have attempted at monotherapy with the ceiling doses, and this has not resulted in the patient actually being seizure free. So if the trials of this combination therapy do not bring about any benefits, or the treatment isn't working, then we should revert back to the original treatment that the patient was on that actually had the most sufficient outcome, such that you can have this balance between effectiveness in reducing the seizure frequency and the tolerance of the side effects. Now, remember that if seizures are not controlled with the first anti-epileptic drugs, then we're going to be gradually introducing a second drug, then we slowly withdraw the first drug. Then if the person is not seizure free when we do this, then we can now contemplate about starting combinational therapy. Remember that epilepsy is one of the few disorders where you can actually prescribe the brand names, which are the non-generic names, because usually different brands have different levels of the drug. Then routine monitoring of the drug levels, like I said, in the blood is not really necessary and is only reserved for assessing compliancy and toxicity. So measuring sodium valproate levels, for example, is rarely useful because even the levels in the blood greatly fluctuate. And there is some interaction between certain anti-epileptic drugs, which I mentioned, for example, between sodium valproate and lamotrigine, but the newer, quote-unquote, newer drugs have fewer interactions. And then another recommendation, or another thing that you really need to take note of, is PHENYTOIN previously was used as the first-line anti-epileptic drug, but now we no longer use it commonly. Even in our country, we no longer use it. We only reserve it for emergency setups, for example, someone presenting with a status epilepticus. Then the anti-epileptic drug of choice largely is going to depend on the type of seizure. So traditionally, the drugs are going to be divided into older groups of drugs, which were created a long time ago. These ones have a lot of drug-to-drug interaction between each other and between other drugs. Then you have the newer drugs, which have lesser drug-to-drug interaction. But of course, even these newer drugs now have been available for many years. So the first group of drugs are what we call broad-spectrum anti-seizure drugs. These are the ones that you must keep in mind, because these ones are effective for most focal onset seizures. They're effective for various types of generalized onset seizures. If there's one drug that I want you to remember, is sodium valproate, because it can be used for absolutely almost all the different types of seizures. Then other drugs that to keep in mind are things like lamotrigine, LEVETIRACETAM, TOPIRAMATE, as well as zonisamide. So these are the different drugs that are available. Then for the focal seizures and the generalized onset tonic-clonic seizures, the newer anti-seizure drugs such as clozapam, clonazepam, lamotrigine, LEVETIRACETAM, PREGABALIN, TOPIRAMATE are no longer more effective than the drugs that were already established. The only reason why we prefer these drugs over the older drugs is because they have a fewer side effects and they are better tolerated and fewer drug-to-drug interaction with the other medication. Now, remember that there are different types of seizures that you can get, and these different types of seizures can be resulting in different types of medications being prescribed. For example, if someone has an epileptic spasm, or which is formally referred to as an infantile spasms, or someone has this atonic seizures or myoclonic seizures, these are very difficult to treat, and often valproic acid or vigabatrin is actually preferred, and this can be followed by clonazepam. For epileptic spasms, corticosteroids for about 8 to 10 weeks are often effective, and the optimal regimen is rather controversial. With ACTH, about 20 to 60 units IM once a day, we can actually use this, and a ketogenic diet, which is a very high-fat diet that induces ketosis, may actually be helpful, but is difficult to actually maintain. Then for the patients that have juvenile myoclonic epilepsy, then lifelong treatment is with valproic acid or another anti-seizure drug, which is usually recommended. Carbamazepine, carbazepine, and gabapentin can actually exacerbate these type of seizures. So as I already talked about earlier on, you can have one type of antiepileptic drug actually exacerbating seizures. We had such a case where a child was on carbamazepine and they wanted to introduce another drug. I'm just not so sure. I don't remember the type of drug that they wanted to introduce. But once they introduced the second drug, the mother said that the child actually even worsened and the seizures became worse, such that they had to revert back to carbamazepine that the child was already taking. Then LAMOTRIGINE can actually be used as second-line monotherapy, especially for those that are women of childbearing age, or as an adjunctive therapy for those that have juvenile myoclonic epilepsy. However, it can aggravate myoclonic seizures in some patients with juvenile myoclonic epilepsy. For those that have febrile seizures, drugs are actually not recommended unless the child is going to be having these subsequent seizures in the absence of a febrile illness. So previously, many physicians gave phenobarbital or other anti-seizure drugs to these children with complicated febrile seizures to prevent these non-febrile seizures from developing, but treatment and research showed that it's not really effective, and the long-term use of phenobarbital actually reduces the learning capacity of the child. Then for the seizures that are due to alcohol withdrawal, anti-seizure drugs are not recommended, and instead we treat the withdrawal syndrome, and this tends to prevent the seizures. So treatment usually is going to include a benzodiazepine. Then with the adverse effects, remember that the different adverse effects of an anti-seizure drug may influence the choice of the drug for an individual patient. Certain side effects tend to be much more prominent in certain individuals than others. So for example, if an anti-seizure drug that is causing weight gain, for example valproic, may be the best option for someone who is overweight, and TOPIRAMATE and zonisamide may not be suitable for this patient with a history of kidney stones. So some side effects of the anti-seizure drugs can actually be minimized by increasing the dose gradually, and overall the newer anti-seizure drugs have this better advantage over the older drugs because they are better tolerated, they're less sedating, and they have a fewer drug-to-drug interactions. All the anti-seizure drugs may cause an allergic type of reaction, a scarlatiniform type of rash, or a mobiliform type of rash. And some types of seizures may be worsened by certain other antiepileptic drugs. For example, pregabalin and lamotrigine may actually worsen myoclonic seizures, and carbamazepine may worsen the absent seizures. It may also worsen the myoclonic and the atonic seizures. Then what about antiepileptic drugs in pregnancy? Before we come to talk about the different drugs that are common in Zambia. So remember that these anti-seizure drugs are usually associated with increase in risk of teratogenicity. So the fetal antiepileptic drug syndrome is going to be including things like cleft lip, cleft palate, cardiac defects, microcephaly, growth retardation, developmental delays, abnormal facies, limb as well as digit hypoplasia, and these tend to occur in about 4% of the children of women who take these anti-epileptic drugs during the pregnancy. But because the uncontrolled generalized onset seizures during pregnancy can actually lead to fatal injury and death, we actually do continue the treatment during pregnancy regardless of these side effects that can happen to the fetus. And for women that actually want to give birth and they are already known anti-epileptic, we do counsel them on these side effects and the risk of these, which should be put into perspective. And remember that if she takes alcohol, this actually increases the toxicity of the fetus more than any other type of anti-seizure medication. And many of these anti-seizure medications are going to actually be decreasing the levels of folate and B12 in the serum, as you see that most of these seizure medications are going to have anemia as a side effect. So it means that oral vitamin supplementation must be given, and this can actually help in preventing this effect. Remember that taking the folate supplementation even before conception helps reduce the risk of neurotube defects, and is actually recommended to all children who are of childbearing age and those that are taking anti-seizure medication. So the risk of this teratogenicity is less when you have someone taking a single drug, and varies from drug to drug. There are some which are a bit safer, but there is no anti-epileptic drug which is completely safe in pregnancy all of them do have some risk. The risk of carbamazepine, phenytoin, valproic acid is relatively high, and there's evidence that they actually have caused some congenital malformations in humans. Then the risk of neurotube defect is somewhat greater with valproic acid than all the other commonly used anti-seizure medication, but the risk is actually lower with the newer drugs like lamotrigine, which seems to be less. So you may contemplate about switching this woman to a different anti-epileptic drug if she's coming into pregnancy, or she may want to take the risk of actually continuing with the same drug and running the risk of developing this fetal anti-epileptic drug syndrome. So in view of this increased risk of these neurotube defects and these defects that are associated with anti-epileptic drugs, particularly with the following drugs: carbamazepine, lamotrigine, oxycarbamazepine, the phenytoin and valproic acid, women that are actually taking these drugs and decide to get pregnant must be counseled and informed of all the consequences that may arise. Those that wish to continue with the pregnancy must be referred to an appropriate specialist for advice. And when the women actually become pregnant, they should be counseled and offered antenatal screening, and they should be checking constantly for alpha-fetoprotein, which may be risen in terms of fetal neurotube defects. Then also you should get a second trimester ultrasound scan. Now here are some of the drugs that are used in the different types of seizures. So for the generalized tonic-clonic seizures, our first line monotherapy is valproic acid in our setting here. This drug here I haven't seen commonly being used here in Zambia. Then our second monotherapy or our adjunct treatment could either be lamotrigine, levetiracetam, or TOPIRAMATE. Then our adjunct therapy is, of course, zonisamide. Both of these drugs, I haven't seen them commonly being used in Zambia. Additionally, you may use phenobab, which is somewhat effective and it's sometimes even considered as a second-line monotherapy, but because it's sedating and can cause these behavioral and learning problems in children, we generally tend to avoid it in generalized tonic-clonic seizures. Then we may have various types of focal onset and focal to bilateral tonic-clonic seizures. First line is going to be drugs like carbamazepine, phenytoin, lamotrigine, levetiracetam, the oxycarbazepine, you have the phenytoin and TOPIRAMATE. These are the first line. The second line drugs are going to be valproic acid, zonisamide, and of course a bunch of these other drugs that are listed on the screen that I will not even attempt to pronounce. Then you may have various types of focal onset and focal to bilateral tonic-clonic seizures. These are what we call the focal seizures with secondary generalization. Vibagatrin, tigabine, as well as clobazam are actually going to be the third line or adjunctive therapy. Then phenobab also can be used, but of course it's sedating and should be avoided. Then for those that have this typical non-motor or absent seizures, our first line monotherapy, again valproic acid, which is showing up, lamotrigine, ethoxusamide can also be used. And other drugs which are effective are levetiracetam, TOPIRAMATE, and these are the two drugs. Then you may also get a typical type of non-motor or absent seizures. You may sometimes get these non-motor seizures associated with other types of seizures. Again, valproic acid shows up again as our first line monotherapy. TOPIRAMATE, lamotrigine can be used, and these are the two drugs which are not common in our setting. Then clonazepam can actually be used. It's also effective, but it often causes this development of tolerance. There is some development of tolerance to the drug. And then we may sometimes use acetazolamide in the refractory cases. Then for those that have previously referred to as infantile spasms or atonic seizures and myoclonic seizures, valproic acid again is the first line. Vigabatrin is going to be the second line, but of course this has the risk of irreversible visual defects. Clonazepam can also be used. Then you have some patients that also have Dravet syndrome. Again, valproic acid and TOPIRAMATE can be used as an adjunct. And of course, those with tonic and or atonic seizures in Lennox-Gastaut syndrome, valproic acid again shows up. TOPIRAMATE, lamotrigine also can be used as a first line. And then cannabidiol, which I think should be cannabis, is used as an adjunct therapy related to cannabis, or of course the structure that's going to be in marijuana. Then clobazam can also be used, and sometimes as an alternative of adjunct therapy for atonic seizures. For those that have juvenile myoclonic epilepsy, valproic acid again is the first line. Then of course second line could be lamotrigine, though this can worsen the seizures sometimes. Levetiracetam, TOPIRAMATE, and zonisamide. Then for the unclassified seizures, again, valproic acid as a first line, lamotrigine as a second line, levetiracetam, topiramate, or zonisamide as a third-line monotherapy or adjunct therapy. Then for those that present in status epilepticus, phenytoin, levetiracetam, valproic acid, and to some extent phenobarb, which can be used as a first line. Now, the drugs that are available commonly in Zambia are going to be including carbamazepine, plentifully available. Valproic acid is available, but a bit costly. Lamotrigine is available. Levetiracetam is very costly. Phenobarb is available. Topiramate, PHENYTOIN, PREGABALIN, acetazolamide, though we don't commonly use it for the treatment of seizures. So we'll begin with carbamazepine. So one of the indications is that it's going to be used as a first-line treatment for the various types of focal onset seizures. It's also going to be used for the seizures that are beginning as focal seizures with secondary generalization. We call them as focal to bilateral tonic-clonic seizures, and then as well as primary generalized tonic-clonic seizures. That's the grand mal seizures. You have to take note that this drug was initially marketed for trigeminal neuralgia and may actually worsen myoclonus and can actually exacerbate seizures in patients with Dravet syndrome. Now, what's the dosage of this drug? So ideally with the adults, we start off at 100 milligrams to 200 milligrams once a day or twice a day. Then we gradually increase the dose to about by 100 to 200 milligrams every week until we get the best response. Our usual dose is about 0.4 to 1.2 grams in a day. Then the maximum dose should be about 1,600 milligrams daily. But of course, some other experts can even exceed this. Then with children, we give it at 5 to 10 milligrams per kg orally, given in divided doses. And up to 1 year, we give 100 to 200 milligrams per day. If they are between the ages of 1 year to 5 years, 200 to 400 milligrams per day. If they are between 5 to 100 years, 400 to 600 milligrams per day. If they are between 10 to 15, 0.4 to about a gram per day. These drugs are contraindicated in bone marrow depression or bone marrow suppression. They're contraindicated in porphyrias and AV conduction abnormalities. Certain side effects to take note of include aplastic anemia, leukopenia, thrombocytopenia, agranulocytosis, Stevens-Johnson syndrome, dizziness, drowsiness, skin rash, transient diplopia. So it means that you should get routine LFTs as well as FBCs as you monitor them. If you see that the LFTs are deranged, you must contemplate actually tapering down this drug and eventually stopping it. That's why most of the drugs actually usually prescribed with folic acid, because like I said earlier on, they do inhibit the synthesis of folic acid or the metabolism of folic acid. So interactions with this drug, so it can lower the plasma concentration of the following drugs: clobazam, clonazepam, lamotrigine, topiramate, valproic acid, tiagabine, PHENYTOIN, but sometimes it may actually increase the concentration of PHENYTOIN, zonisamide. Then it may lower the plasma concentration of ethoxyzamide and primidone. And when it comes to valproic acid, which is the drug that I said you must keep in mind, this one can be used for all the forms of epilepsy. It works very well in absence seizures, that the petit mal type of seizures. It works in myoclonic type of seizures. It works in atypical absence seizures. It works in atonic and tonic seizures. In adults, we give an initial dose of 600 milligrams orally in 2 divided doses. This should be taken after a meal. Then we increase by about 200 milligrams every 3 days to a maximum of 2,500 milligrams or 2.5 grams a day. Our usual dose of these patients is going to be roughly at around 1 to 2 grams daily. So that's about 20 to 30 milligrams per kg daily. For the neonates, you can give it as IV or orally, 8 hourly, same dose of 6 to 12 milligrams per kg. And if it's given IV, it must be given over 3 to 5 minutes. For the pediatric patients that are below 20 kg, initially we give it at 20 milligrams per kg in 2 divided doses. If they're above 20 kg and they are under 12 years, initially we give 400 milligrams daily in 2 divided doses. Then of course we increase according to the response. Our usual range that we aim for is 20 to 30 milligrams per kg, but we shouldn't exceed 35 milligrams per kg. Certain side effects include hepatotoxicity, menstrual disturbances, pancreatitis, thrombocytopenia, extrapyramidal disorders, aggression, anemia, confusion, nystagmus, transient hair loss, which usually when they have this regrowth of the hair, it becomes curly. And they may also have weight gain. Contraindications of the drug include patients that have acute liver disease, bleeding disorders, a family history of severe hepatic dysfunction, as well as acute porphyrias. So it means you have to monitor the LFTs before therapy and ideally during the first 6 months of treatment, especially for patients that are at risk. Also, do not forget to do a routine full blood count. Interactions. So this drug tends to lower the concentration of the active metabolites of oxycarbazine. It also raises the plasma concentration of an active metabolite of carbamazepine and lamotrigine, primidone, phenobarb, and phenytoin, but sometimes it may also lower the concentration of phenytoin in the blood. It tends to rise the plasma concentration sometimes of ethoxusamide, primidone, but usually it has a tendency for significant increase in phenobarb levels, and rufinamide. Then with lamotrigine, this was initially actually developed because we realized and we observed that most of the anti-epileptic drugs tend to have an antifolate activity. They inhibit one of those enzymes that is essential for folate metabolism. So that's why this drug was initially created. So this one can be used as a second-line therapy, monotherapy, or as an adjunct for generalized onset tonic-clonic seizures. It can be used for first line for various types of focal onset and focal seizures with secondary generalization. It can be used as a first line for typical non-motor absence seizures, and even first line for atonic seizures in Lennox-Gastaut syndrome. And we can actually use this drug in combination with valproic acid. Remember that lamotrigine can actually aggravate myoclonic seizures in some patients with juvenile myoclonic epilepsy and also in patients with Dravet syndrome. Contraindications include renal failure, hepatic failure, and hypersensitivity, and some certain side effects include thrombocytopenia, aplastic anemia, blurred vision, nystagmus, diplopia, exacerbation of Parkinson's disease, Stevens-Johnson syndrome, hypersensitivity reactions, rash, and tremor. Some interactions generally tends to rise the concentration of the active metabolite of carbamazepine, though evidence from most of the research is still conflicting. And if we want to stop this drug, generally we taper it off over 2 weeks or longer, and we should avoid abruptly stopping the drugs. Generally, with most of these anti-epileptic drugs, we should avoid abruptly stopping them. Then we do also do a routine screening of the full blood count because it's hematotoxic. Now, what's the dose of lamotrigine? So if you're giving it as a monotherapy, whether it's an adult or child over 12 years, initially we give it at 25 milligrams once a day for 14 days. Then we increase to 50 milligrams once a day for a further 14 days, and we increase by a maximum of 50 to 100 daily every 7 to 14 days. Our usual maintenance dose is roughly around 100 to 200 milligrams daily in 2 divided doses, so up to 500 milligrams daily as required. Then if it's given as an adjunct therapy with valproic acid, if it's in adults, initially we start at 25 milligrams on alternate days for 14 days, then 25 milligrams once a day for another 14 days. Then we can increase by a maximum of 25 to 50 milligrams daily every 7 to 14 days. And our usual dose again is going to be 100 to 200 milligrams daily in about 1 to 2 divided doses. For children that are between the age of 2 to 12, initially we give 150 micrograms per kg daily for 14 days. And those that are weighing under 13 kg may actually receive 2 milligrams on alternate days for the first 14 days. Then we give 300 micrograms per kg once a day for another 14 days. Thereafter, we increase by a maximum of 300 micrograms per day daily every 7 to 14 days. And our usual dose is about 1 to 5 milligrams per kg daily in 1 to 2 divided doses. Our maximum single dose must be 100 milligrams. So you do not exceed 100 milligrams on a maximum dose if you are giving it as an adjunct therapy with valproate. Then if it's an adjunct therapy with an enzyme-inducing drug, any drug that can induce the enzyme without valproate, then we initially start at a higher dose of 50 milligrams once a day for 14 days because that drug is going to be inducing the breakdown of lamotrigine. So then afterwards, we're going to be going at 50 milligrams twice a day for another 14 days. Then thereafter, we increase by a maximum of 100 milligrams daily every 7 to 14 days. And our usual dose is going to be 200 to 400 daily in 2 divided doses. So up to 700 milligrams daily has actually been required. In children that are between the ages of 2 to 12 years, initially we start at 600 micrograms per kg daily in 2 divided doses for 14 days, then 1.2 milligrams per kg daily in 2 divided doses for another 14 days. Thereafter, we increase by a maximum of 1.2 milligrams per day every 7 to 14 days. Our usual maintenance dose is about 5 to 15 milligrams per kg daily in 2 divided doses, and our maximum single dose is about 200 milligrams. Then we move to the next drug, which is levetiracetam. This one here was initially licensed for monotherapy and adjunct treatment of partial seizures with or without secondary generalization, and also for adjunctive therapy of myoclonal seizures as well as primary generalized tonic-clonic seizures. This is contraindicated in breastfeeding women, patients with hepatic involvement, patients with renal involvement, and you may actually need to adjust the doses in patients with renal involvement. Also, just like the other anti-epileptic drugs, avoid suddenly withdrawing the drug. Certain side effects include GIT abnormalities, which are common in most of these anti-epileptic drugs. So things like dyspepsia, diarrhea, abdominal pain, anorexia, weight changes, cough, tremor, headaches, insomnia, anxiety, thrombocytopenia, myalgias, pruritus, pancytopenia, leukopenia, alopecia, and paresthesia. It doesn't have many reported drug-to-drug interaction because it's a much newer drug, and the doses depend on whether you're giving it as monotherapy or as an adjunct therapy. So if you're giving it as a monotherapy or for the partial seizures with or without secondary generalization, either giving it by mouth or IV. If it's an adult or a child over 16 years, initially we give it at 250 milligrams twice a day. We increase according to the response in steps of about 250 milligrams twice daily every 2 weeks. Our maximum dose is 1.5 grams twice daily. If we're giving it as an adjunct therapy or for partial seizures with or without secondary generalization or myoclonic seizures and primary generalized tonic-clonic seizures, if we're giving it either orally or by intravenous infusion, if it's an adult or child over 12 years, then the body weight over 50 kg, initially we give it as a 500 milligrams twice daily. Then we adjust in steps of 500 milligrams twice daily every 2 to 4 weeks with a maximum dose of 1,500 twice a day. If it's a child that is between 4 to 18 years, remember that for those that are 12 to 18 years with myoclonic or tonic-clonic seizures and a body weight under 50, our initial dose is going to be 10 milligrams per kg twice a day, and we adjust it in steps not to exceed 10 milligrams per kg twice a day every 2 weeks, and our maximum is obviously 30 milligrams per kg twice daily. Then with phenobarb, remember this one was indicated for all forms of epilepsy except the absent seizures, and by now we usually reserve it for patients that come in with status epilepticus and seizures in the neonatal period. Then the dose is going to be by mouth, 60 to 180 milligrams at night, and then in children is going to be 5 to 8 milligrams per kg daily. So for the therapeutic purposes, phenobarb and sodium may be considered equivalent in effect, but the plasma phenobarb concentration for optimum response is about 15 to 40 milligrams per liter. That's about 60 to 180 micromoles per liter. Side effects include hepatitis, cholecystitis, respiratory depression, which is very important that you must give this slowly, especially if you're giving it as an IV. You may have these behavioral disturbances, nystagmus, irritability, hallucinations, osteomalacia, megaloblastic anemia, which may be treated with folic acid, Stevens-Johnson syndrome. Generally, it tends to lower the concentration of carbamazepine, clonazepam, lamotrigine, and phenytoin, but it may also raise the concentration of phenytoin, tiagabine, valproic acid, and zonisamide. Then sometimes it may lower the concentration of ethoxusamide. Then with phenytoin, remember this was previously used as first line in certain types of seizures, but now we just reserve it for status epilepticus. It can also be used in trigeminal neuralgia if carbamazepine is not appropriate. If we're giving it by mouth, initially we give a dose of 3 to 4 milligrams per kg daily or 150 to 300 milligrams daily as a single dose or in 2 divided doses, then increase gradually as necessary. Remember with the plasma phenytoin concentration monitoring, and our usual dose is about 200 to 500 milligrams daily. Exceptionally high doses may actually be used. In children, we give it initially at 5 milligrams per kg daily in 2 divided doses. Usual range of the dose is going to be about 4 to 8 milligrams per kg with a maximum of 300 milligrams daily. Then the plasma concentration for optimal response is about 10 to 20 milligrams per liter. That's about 40 to 80 micromoles per liter. And we should counsel the patient to take the medication with or after food. Side effects include the CNS side effects such as nystagmus. It may also cause gingival hyperplasia, and then it may cause coarsening of the facial features. It may cause toxic hepatitis. It may cause liver damage, and just like all the other anti-epileptic drugs, we should avoid abruptly withdrawing it. It may actually lower the plasma concentration of clonazepam, carbamazepine, lamotrigine, an effective metabolite of oxcarbazepine, and then of course tiagabine, as well as topiramate, valproic acid, and zonisamide. It may often raise the plasma concentration of phenobarbital and sometimes lower the plasma concentration of ethoxusamide and primidone by actually increasing the conversion to phenobarbital. With topiramate, it's usually indicated with monotherapy and adjunct treatment of generalized tonic-clonic seizures or partial seizures with secondary generalization. Adjunctive treatment of seizures in Lennox-Gastaut syndrome can also be indicated to use topiramate, or it can be used in migraine prophylaxis. Side effects include nausea, abdominal pain, dyspepsia, diarrhea, dry mouth, taste disturbances, weight loss, anorexia, paresthesia, hypoesthesia, headache, fatigue, dizziness, speech disorders, drowsiness, insomnia, impaired memory and concentration, anxiety, depression, and visual disturbances. It's contraindicated for patients that are breastfeeding. And of course, it does have some interaction with phenytoin. It tends to increase the plasma concentration of phenytoin. Then doses, if it's used as a monotherapy, initially we give it at 25 milligrams at night for 1 week. Then we increase in steps of 25 to 50 daily at intervals of 1 to 2 weeks, taken in 2 divided doses. Our usual dose is 100 milligrams daily in 2 divided doses, with a maximum daily dose of 400 milligrams. In children between 6 to 16 years, initially we give it at 0.5 to 1 milligram per kg at night for the first week. Then we increase in steps of 0.5 to 1 milligram per kg daily at intervals of 1 to 2 weeks, taken in 2 divided doses, and our usual dose is 3 to 6 milligrams daily in 2 divided doses, and we shouldn't exceed a maximum of 50 milligrams per kg daily. We can use it as an adjunct therapy, and we give this initially at 25 milligrams at night for 1 week. Then we increase in steps of 25 to 50 milligrams daily at intervals of 1 to 2 weeks. Then we take it in 2 divided doses. Then our usual dose is 200 to 400 milligrams daily in 2 divided doses, with a maximum of 800 milligrams daily. For children between 2 to 16 years, our initial 25 milligrams at night for the first week. Then we increase by steps of 1 to 3 milligrams per kg daily at intervals of about 1 to 2 weeks, taken in 2 divided doses, and our recommended dose range is about 5 to 9 milligrams per kg daily in 2 divided doses, and also we shouldn't exceed 15 milligrams per kg daily. Then with pregabalin, remember that this is indicated in peripheral and central neuropathic type of pain. It can be used as an adjunct therapy for partial seizures with or without secondary generalization. It can also be used by generalized anxiety disorders. If it's epilepsy in adults over 18 years, our initial dose is 25 milligrams twice daily. Then, of course, it's increased at 7-day intervals in steps of 50 milligrams daily to 300 milligrams daily in 2 divided doses. Then it's increased further, if necessary, after 7 days to a maximum of 600 milligrams daily in 2 to 3 divided doses. For those that have generalized anxiety disorders, for adults that are above the age of 18, the initial dose is 150 milligrams daily in 2 to 3 divided doses, then increased if necessary at 7-day intervals in steps of 150 milligrams daily with a maximum of 600 milligrams daily in 2 to 3 divided doses. This one also doesn't have so much drug-to-drug interactions that have been reported because it is a newer drug. Then the side effects are going to include dry mouth, constipation, nausea, vomiting, flatulence, edema, dizziness, drowsiness, irritability, attention disturbances, disturbances in the muscle control and movement, memory impairment, paresthesia, euphoria, confusion, fatigue, appetite changes, weight gain, and changes in sexual function, as well as visual disturbances and other ocular disorders. Then with gabapentin, this is indicated with monotherapy and adjunct treatment of partial seizures with or without secondary generalization, and not so many interactions also have been reported with this. If it's epilepsy in adults, 300 milligrams on day 1, then 300 milligrams twice a day on day 2, then 300 milligrams 3 times a day on day 3, or initially 300 milligrams 3 times a day on day 1, then we increase according to the response in steps of 300 milligrams daily in 3 divided doses every 2 to 3 days, and our usual dose is about 0.9 to 3.6 grams per day in 3 divided doses. For children between 6 to 12, we can use it as an adjunct therapy only, 10 to 15 milligrams per kg daily initially, then we increase according to the response over 3 days to our usual maintenance dose of 25 to 35 milligrams per kg daily in 3 divided doses until we reach a maximum of 50 milligrams per kg daily in 3 divided doses. So here's a picture that's showing you a much more exhaustive list of the different drugs, the indications to which we use these drugs in, and the adverse effects. So everything I've been talking about, you may actually pause the video because there are some drugs that I haven't mentioned in the previous slide and actually have a read through this. Here's the second group of drugs, which are pretty much explaining most of the drugs that I've been tackling. I've only explained the ones that are common in Zambia in a lot more details. Then this one is more or less a summary of the other drugs so that you have an exhaustive list. You also have these drugs that are present. You may find it wise to pause the video. If you haven't subscribed at this moment and have put in all this effort, what are you waiting for? Hit the subscribe button, drop a comment if you're enjoying these lectures, hit the like button because it obviously does help with the YouTube algorithm. Here's another picture of the same anti-epileptic drugs. As you can see, they are arranged in, I think it should be alphabetical order. Then I think this one should be the last picture. So as you can see, the side effects are quite numerous and it's quite a lot of information to take in, but once you sit down and you read through it, you have a good idea. And whenever you're dealing with patients who are epileptic, you can actually go through this information and actually read up and see if the patient has any other drugs that could possibly interact with your medication. I really hope you enjoyed this lecture on anti-epileptic drugs. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.